In this video, I am discussing about the short or obese. So, short or obese, short stature history come, obesity also history come. So, first, as usual, the onset, course, and durations, what make it better and what make it worse. Plus FOPSM, FOPS. So, F for features. So, is there any unusual features present or not? O for onset, where you first notice the child that is short or obese started. Then P for puberty, is that puberty is uh, started or not? We can ask the patient puberty and the parents puberty. Very important, parents puberty, because sometimes some syndromic features has delay puberty. Sometimes we know that constitutional delay of short statures. These are then school performance, very important, short stature with school performance, because hypothyroidism we know that school performance is decreased. Then about the measurement, what about the weight, height, BMI, mid parental height, sitting height, it's very important about the weight of the children's. Is BMI, is that any chronic condition, the child is not also gaining weight, and mid parental height, parent height also, that genetically short stature or genetically obese or not. These are sitting height, proportionate short stature or disproportionate short stature. I'm again repeating this: short stature and obesity, if the chief complaints mother telling, then first onset, course and duration, what make it better and what make it worse. Then FOPSM, F for the features, is there any unusual features you notice, different look, syndromic features. O for onset, when it started. P for puberty, both we ask, the patient puberty and the parent puberty. Then about the school performance, S for school performance. M for the measurements, measurements about the weight, height of the children, BMI, mid parental height, both parents height and the sitting height. Now short and non-obese, we can classify short and non-obese and short, DD of obesity, next we'll telling. So short and non-obese, that is proportionate and disproportionate classify. Proportionate, again, normal IQ and decreased IQ. Normal IQ like familial short stature, constitutional delay of short stature, any chronic illness, Russell Silver, X preterm. So remember this, familial short stature, constitutional delay of short stature, we keep in our differential diagnosis, any chronic illness, these are. Decreased IQ, when IQ decrease, that is a syndromic feature like Turner syndrome, Noonan syndrome, Williams syndrome, Cornelia de Lange syndrome. Among them, once Turner syndrome come on, short stature history, remember. Then also Turner syndrome, we know that delayed puberty and some features. Disproportionate short statures also associated with normal IQ and decreased IQ. So normal IQ with disproportionate short statures are achondroplasia, hypochondroplasia, rickets, osteogenesis imperfecta, and Ellis Van Creveld. Where decreased IQ occur in mucopolysaccharidosis and Sanfilippo. These are very important. All are common other stations. Now differential diagnosis of obesity. So chief complaints is obesity. Then we need to discuss about the obesity. Is that short obese or tall obese? So short obesity we can again classify normal IQ and decreased IQ. Normal IQ with short and obese are like endocrine growth hormone deficiency, Cushing syndrome, hypoparathyroidism, pseudohypoparathyroidism. And short obese with decreased IQ syndromic like Down syndrome, Prader-Willi syndrome, Lawrence-Moon-Bardet-Biedl syndrome. So all the features we know that Down syndrome, some features, that is flat, hypotonic, upward eye, depressed nasal bridge, there is syndactyly, there is a increased gap between the first and second toe, sandal gap, that is simian palmar crease. Prader-Willi syndrome, that is the child eating lots, but at the infant the child will not eating later. And Lawrence-Moon-Bardet-Biedl syndrome, we know that extra digit present, kidney problem present, low IQ, child wearing glasses, eye problem present. Now tall stature with obese, that is simple can be, and Beckwith-Weidman syndrome and Klinefelter syndrome. Beckwith, we know that there is hypoglycemia present, child is macrosomic at birth time, child has hemihypertrophy. Beckwith-Weidman syndrome also common development. Simple obesity is common the history, that is simple obesity the child. These are Cushing syndrome, we know that any the child may be taking any steroid associated with any chronic conditions like it can be bronchial asthma, nephrotic syndrome, it can be SLE, any JIA, these are. So this is all about short and obese analysis. Thank you.